Welcome to the #1 show and the source of truth for all things medtech. Here, we reveal the secrets and stories behind the investments, science, and commercialization of the medtech industry. Every week, we'll take you on a wild ride with the biggest names in the game, from entrepreneurs and investors who are shaking up the market to healthcare providers who are revolutionizing the way we think and practice medicine. So hold on tight and get ready for a journey like no other. This is the State of MedTech. Hey everybody, welcome back to the show. And as a reminder to our listeners, this episode is eligible for a CME credit that you can unlock. So you can go ahead and check the show notes below and click the link and take a few seconds and write down what you learned from this episode. Whether you're a physician's assistant, nurse practitioner, or clinician of any type, you can unlock your AMA PRA Category 1 credit. And that's courtesy to our partner and sponsor for this episode, which is GT Medical. GT Medical is a really fascinating company that I've been following for quite some time now. And essentially what GT Medical is that they are a medtech company with a surgically targeted radiation therapy, or otherwise known as START, with patients with inoperable brain tumors. They have a small device that is essentially placed by the neurosurgeon at the time of resection, which is called GammaTile therapy. And what GammaTile therapy does is it gives patients a head start in the fight against brain tumors, delaying the recurrence and potentially extending survival. What I really love about this company, what's exciting about it, is that rather than having sort of the shotgun approach when it comes to radiation therapy, they have a very precise and targeted approach to therapy. And you'll see in this episode, this episode is something that you can definitely listen to. But I will say that there are some times that our speakers are going to bring up a few slides to reference. So you can either see that on video format on Spotify or on YouTube. And so it's a great lecture that we're going to be jumping into. And so our speakers today are actually a really fantastic duo. You know, when it comes to this type of therapy, you know, there are two really important people that are involved. One is the neurosurgical oncologist who's going to be essentially resecting and placing the GammaTile therapy, but also the radiation oncologist who's going to be dealing with the post-op patient management. And so we have Dr. Matthew Sean Peach, who's a MD, PhD, and assistant professor and director of brachytherapy services over at East Carolina University Health Beaufort Hospital. And then from the neurosurgical side, we got Dr. Jay McCracken, who's a neurosurgical oncologist over at Piedmont Hospital in Atlanta. And so this episode is focused on redefining brain cancer treatment with surgically targeted radiation therapy. It's a really exciting approach. I think it's fantastic because it gives clinicians a more controlled approach to when it comes to treating brain tumors, and more importantly, at least from my perspective on what I've interpreted about the technology and how it's being placed, is that it gives you a lot more of a precise treatment when it comes to brain tumors. So with that being said, here's our episode with Dr. Jay McCracken and Dr. Matthew Sean Peach. And again, don't forget to unlock that AMA PRA Category 1 CME credit by clicking the show notes below. And if you are a radiation oncologist or a neurosurgeon who's interested to learn more about GT Medical and GammaTile therapy, I highly encourage you to go to their website and check it out. You can head over to gtmedtech.com. I have a lot of fantastic resources there, and I would really encourage you, go and check it out yourself. Get booked for a demo or go to one of their trainings, and you'll be able to see the technology in action. So with that being said, let's get on to our episode. Thank you all for joining us. Maybe, you know, before we kind of jump onto the, you know, topic of discussion, maybe if you can both kind of quickly introduce yourself, give a little bit more color to your backgrounds. And Dr. McCracken, we'll go with you first.
Yeah, so I'm a neurosurgeon. I've been practicing now for well over a decade. I specialize in brain tumor work, really everything from benign to malignant brain tumors of the brain, the skull base, the pituitary gland, and spinal cord. And I've been in Atlanta now for quite a long time, my wife, and you know, we do a ton of cases. We serve over about 400 new patients a year. We do everything, clinical trials, upfront disease, recurrent disease. We treat a little bit of almost everything.
Fantastic. Fantastic. And Dr. Peach, how about you? If you can give a little bit of background to yourself before we get started.
So yeah, I'm a radiation oncologist, have been practicing for 8 years. I was very lucky to do my training at the University of Virginia, which has a very, very strong brachytherapy background. And so being more surgical oriented, I got a lot of experience with that. And I took that with me to Greenville, where I'm the main physician that does procedural radiation brachytherapy. Been here for 4 years, and it's kind of an interesting area. We're kind of the main academic / big medical institution in the eastern 1/3 of North Carolina. And there's a lot of bays, there's a lot of islands, there's a lot of bridges. So things might be, as the bird flies, not that far away, but we have a lot of patients that travel extremely far to get to us. So it's kind of been a very interesting experience.
Yeah, and I think that's one of the more interesting things for both of you, given that not everybody can just go and get a procedure for neurosurgery anywhere in the country. You have to go to one of the largest centers. And so as a result, based on where both of you guys are at, you probably see a very large amount of patient population coming in. So, one of you is surgical oncologist, the other one radiation oncology. Maybe let's get started with why both of you have decided sort of to implement GammaTile, and what is GammaTile?
So GammaTile is a intraoperative source of radiation that we place in a resection cavity after a brain tumor has been resected. So after typically somebody like me would go in and remove a tumor, especially a malignancy that we know is going to need some form of radiation afterwards, we place these small seeds of radiation within the resection cavity to let it start working immediately on any microscopic disease left behind. This is actually a really great tool because it allows the patient to avoid other forms of external beam radiation later. It's kind of a one-stop shop for getting all of their treatment in one. And for us, it's been really amazing. We've had patients who we are concerned about whether or not they're going to have adequate follow-up, whether they're going to come back and get multiple rounds of radiation therapy later. And especially for people who live in rural parts of Georgia and maybe don't have access to immediate care or care that they can get reliably, it's been a wonderful tool for us to use for them.
Fantastic. And Dr. Peach, how about you?
Yes, sir. Around a lot of the similar lines, the kind of why we liked using it has evolved over time. Initially, was the remote ness of a lot of our population. It was nice to be able to do a craniotomy and then give the radiation at the same time and not have to figure out how to bring someone back for 1 to sometimes multiple weeks of extra radiation therapy. And so that kind of what got us going. Then once we started using it, we really found that because it's brachytherapy, it's implanted radiation, the dose falls off very fast. And that opened up numerous patients who had had several rounds of radiation that otherwise through external beam means could not get any more radiation. So we were really excited about that. And then sort of our latest phase has been using it both in the recurrent, both for recurrent and also upfront glioblastoma. Essentially, biologically, you get more dose in with brachytherapy than you can with external beam. And so we're excited to be involved in the early work with that.
That's fantastic. And it's really exciting to see, because even for myself, I mean, at one point, a long time ago, about 12 years ago now, I remember being in medical school and learning about glioblastoma and pathology and everything, and there was really not much you can do. And of course, the big thing about radiation is just it was kind of like a shotgun approach, and it seems like this is a much more targeted approach, and we'll kind of get more into that. So next thing I kind of want to cover is how does GammaTile, differentiation is really important. And so that's the first thing that I always think about when it comes to medical technology. But how does this differ technically from other forms of radiation, such as one is external beam radiation and the other one is traditional brachytherapy?
So how this kind of differs from traditional radiation therapy is that with traditional radiation therapy, you have a very large linear accelerator that is making X-ray beams. It's coming from the outside, it's going in. But with that, there's always some dose that passes through. You get an integral dose. So no matter what, there's some normal tissue that's a bystander of that radiation. What makes brachytherapy different is that instead of coming from the outside in, you're placing radioactive sources either permanently or temporarily, in the case of GammaTile, permanently, into where the target of treatment is, going from the inside out. And with the very sharp dose fall off, you can spare critical structures in the brain significantly in ways that you can't with any other form of external beam radiation therapy.
Interesting. And, just kind of, bouncing back off of that, Dr. McCracken, as a neurosurgeon, I mean, what type of brain tumors are best suited for treatment when it comes to GammaTile? I know there's a variety, but they're probably not something you can use in every single case unless I'm mistaken by that.
No, you're right. I mean, we typically, we consider for patients who are going to need some form of radiation after resection, right? So there are a lot of benign brain tumors that we remove that we typically do not treat with radiation. So there's really no reason to use it for those. I'm talking benign meningiomas, pituitary adenomas, acoustic neuromas. We typically do not use that in those patients. Where we do use it quite a bit are metastatic disease. So metastatic disease from breast, colon, lung are the most common types of brain tumors that we see. And those patients they typically need either radiation alone or surgery plus some form of radiation. And so we look to those patients to say, are we going to resect this? And then are they going to need adjuvant radiation afterwards? And typically the answer is yes. We use these in glioblastoma quite a bit. So glioblastoma is a horrifically malignant disease that always needs some form of radiation. And so what we are working with GammaTile is, do we deliver this purely in an external beam fashion like we have for decades? Or now are we resecting the tumor, putting in brachytherapy in the form of GammaTile, and then either in the recurrent or upfront setting to see how these patients are doing, which is something that has not been done in decades, in the hopes of trying to move the needle in treating these patients with glioblastoma. Additionally, there are other forms of very malignant meningiomas, what we call grade 2s and grade 3s, that have a high incidence of recurrence. And so when those patients recur after their initial treatment, we are going back in for a second or potentially third resection. And then at that point, using GammaTile to kill any of the small cells which are left behind so that they don't recur for another time.
Interesting. And just on that, I think you may have covered it very quickly, but can you talk a little bit about, like, when patients receive GammaTile, do they have to wait to begin adjuvant therapy, such as chemotherapy, or what does that look like?
So we typically, we wait a reasonable period. I mean, 2 to 4 weeks. I mean, we really want to make sure that the patients are doing well after surgery. Their wounds are healing nicely. We don't want to give them something like chemotherapy, which is going to knock down their immune system even worse right after surgery. So we typically wait 2 to 4 weeks, but the radiation alone does not prevent them from having, to not get immunotherapy or chemotherapy. It's more from a surgical standpoint. Yeah.
Got it. And just to avoid from covering your face up too much, I just want to remind the audience, if you have a question for Dr. McCracken or Dr. Peach, go ahead and just drop it in the comments. Again, we're live not only on LinkedIn, but we're also live on Twitter and Facebook. So let me jump to next question. So can you kind of talk about some of the main benefits when it comes to using GammaTile treatment for brain tumors? Because it sounds like there's a variety of them, but what if you had to narrow it down to 2 or 3 key ones, what would those be?
Well, I guess I could say that the one thing is immediate treatment. So for these more aggressive tumors, normally, if you're going with external beam radiation and you're going through potentially a maybe well-healing, sometimes not well-healing craniotomy scar, you got to wait 4 to 6 weeks for that area to heal up before you consider doing radiation. With GammaTile, there isn't that wait. And often, especially with glioblastomas, you'll get imaging immediately after resection, and then you don't see any tumor. But when you get a MRI at the time of planting the external beam, there's already some coming back. So you're losing that kind of, instead of starting off being behind the cancer with external beam, you're hitting it right away. So one, that's very good. Two, the dose, you just can't get dose that is biologically that high. And three, you can't get dose that is also so conformal to what you're treating. So you don't get a lot of random spill in other areas.
Got it. And Dr. McCracken, before I have you jump in, do you mind if you either, I guess, sit up higher or maybe angle your camera a little bit down? So, there you go. That's a lot better. Yeah, perfect. All right. Yeah, and Dr. McCracken, what about you? What's your take on it?
We've really found that in patients who have failed multiple rounds of radiation in the past for one reason or another, going back in and then implanting, GammaTile has been a great way for us to prevent local recurrence, because it's very difficult sometimes to target radiation, external beam radiation, just based on a post-operative MRI, right? Or you're also worried about giving too much dose to a critical structure, the brainstem, the optic nerve, things that you don't want to injure. And so one of the best things about being able to do it at the time of surgery is that I can physically see where we are, and I can place the tiles in a way that I know we're not going to hurt other parts of the brain. And so it allows us to treat residual disease or microscopic disease immediately without having to, just guess on a postoperative MRI. And I think one of the biggest benefits that we've seen is, and I talk about this all the time. We have a lot of patients who come to us and they are neurologically already devastated, right? They've had a massive seizure. They're already weak in their arm and leg because the brain tumor is pushing on the motor strip, which controls those functions in the brain. We know those patients are going to have to go to some form of rehab before they are strong enough to get any sort of external beam radiation or chemotherapy. And so the problem with that is that if you delay treatment too long, those tumors are going to come roaring back, especially in the case of glioblastoma. And so those patients who come in already in a very difficult situation, if we are able to resect their tumor and place GammaTile, I'm fine with them going to rehab, because now they can get as strong as they want over the next 2 or 3 months, but they're already getting radiation that they didn't have to wait for instead. And so to me, that is a tremendous benefit for some of these patients.
And to piggyback on that, that's a very significant thing, the rehab issue, because depending on what state you are in, some states insurance will not pay for transportation from SNFs or rehabs. So,
interesting.
So if you live way out, you're in a rehab that doesn't have transportation, it might be you're instead of starting at 4 weeks to 6 weeks, you might be starting 8 weeks later, depending on how rehab goes. Don't have to worry about that with GammaTile.
Got it. Well, and that's kind of a good segue that I want to ask both of you again. Technology is always great, but every technology is going to have its own limitations. So maybe you can cover some of the limitations maybe that are associated with GammaTile, and of course some of the challenges. Again, it's a new technology. This is not something that people are trained in fellowship to use. So what are some of the limitations and challenges when it comes to using it?
So, the one thing you definitely need is you need something that is either looks like it can be, for the most part, resected, or with a little bit of disease left that can be covered by the tiles. There's kind of ways you can place them to cover that. For patients that are not an operative candidate, unfortunately, there's no way to deliver those tiles. The other thing that we're kind of learning which areas might be a little more disadvantageous is anything where you're right on top of the optic chiasm. That's where the optic nerves kind of integrate and then go out towards the eyes. That area is one of the more sensitive areas to the brain. And so that's a place where there's been a handful of cases where we could do the craniotomy, but we couldn't really trust that maybe that area would get too much dose. So fortunately, though, most tumors end up being more higher up in the cortex, away from that area. So it's something that we don't encounter all too often.
Got it. And Dr. McCracken, how about you?
I think from a limitation standpoint, we do run the risk of giving too much radiation if somebody's already received a large dose in the past. So even if it was 6 months, 12 months, 2 years prior, if you're doing radiation, it can be additive within the brain. And so we do have to be careful about the dose somebody else has received and how much dose we are giving with the new tile implantation. So we are very cognizant of that as well.
Got it. So maybe kind of another good segue is like, to date, are you pleased with your patients, the clinical and safety outcomes after being treated with the GammaTile? And again, like, not everything is perfect. So please, be candid in this,
Yeah. I mean, I think from a surgical standpoint, we have not seen an increase in things like infections or complications related to the procedure. Every surgery has a small, percentage of complications that it comes with, whether it be infections, spinal fluid leak, bleeding, seizure. From our standpoint, we have not seen an increase in those when we implant in these patients. So I think from a implantation and tolerance standpoint, it's been very safe. I don't really have any concerns about that. And so, from a follow-up and long-term standpoint, I've seen some patients who have lived well beyond what we would have ever expected because we're able to treat them locally. The first patient we treated was a lady who had horrible metastatic breast cancer to the brain. She had already undergone 3 surgeries, multiple rounds of external beam radiation, and this had just kept coming back. And so we resected her, put in the GammaTiles, and then ultimately she lived another year without any progression in the brain, and then ultimately succumbed to her systemic disease. In the same vein, we've also seen some of our recurrent GBM patients last well beyond the time we would ever expect, well beyond sort of the standard, 12 to 15 month life expectancy. Lots of people living well on to, 18 to 24 months. And so from our standpoint, it's really given patients a lot of hope, and it gives me hope too, that hopefully we're moving the needle for some of these people.
That's fantastic. And Dr. Peach, what about you as a radiation oncologist? What's your take on the clinical and safety outcomes for your patients?
Yeah, so I mean, it is as a new technology. There's always been some cases that have come up where it gets my blood pressure high because I am worried about, especially in the cases where people have had multiple rounds of radiation before, and we really have not had any issues of significant radionecrosis. And in fact, radionecrosis is basically dying off of brain tissue as a result, normal brain tissue as a result of radiation. We see radionecrosis at a lower rate than what is published out there on GammaTile. So we're really not having an issue with radionecrosis, and we've had some delicate cases. We had a pediatric patient that had a high-grade glioma, had one craniotomy just posterior to the motor strip, had a second one just underneath it, and then popped up with recurrence anterior to it. So basically, in one of the worst areas you could do surgery on a teenage boy. In this particular case, with the assistance of 5-ALA, which lights up in high-grade gliomas, we were able to do the craniotomy, get a very good resection, place tiles in there, and there has been no complications whatsoever. Whereas with his initial surgery, he did have, some permanent hemiparesis on the one side of his body. So it has more than exceeded my expectations from a safety standpoint.
Yeah, and I kind of want to dig into that a little bit more, because this is the thing that makes, I think anything in oncology is difficult. Cancer is a very difficult topic, but I think what makes brain cancer more difficult is that in the process of treating, you can also cause something like a hemiparesis, for example. And so like you might have improved the patient's quality of life when it comes to the cancer, but their quality of life in other areas have now been affected. And so Dr. Peach, I kind of want to, put you on the spot here, and like, how does GammaTile impact the patient's quality of life compared to, let's say, other treatment options?
I think the number one way that it impacts patients is that it's a solution where there wasn't solutions before. We have patients that have had multiple, similar to what Dr. McCracken was talking about, colon cancer, breast cancer, where they have had multiple brain mets over a series of years, systemic therapies, keeping things under control relatively well, have had multiple external beam, multiple gamma knife, and doing any more external beam would just be dangerous. And so, for those patients, we've been able to implant GammaTile, not have any really significant toxicity, and, have patients that are living years afterwards with no recurrence. So I think, these are patients that most likely would have passed had we not been able to do this. And certainly from a quality of life standpoint, it helps to have really good surgeons. You combine that with this device, which really, it hits the at-risk area. When you're doing, unlike breast cancer, unlike colon cancer and lung cancer, when you do an oncologic resection, you're taking out a rim of normal tissue around it to make sure you have everything.
Because you can do that with those organs, right?
Yes.
You can't do that with the brain.
With the brain, that's the thing. With the brain, you go for a maximal safe resection because you want to not have that significant impact on quality of life. Well, for most of these malignancies, it's going to be the first 5 millimeters that's the high yield region of where there would be residual disease from a maximal safe resection. And that is the zone that GammaTile is blasting. And so from a quality of life standpoint, you're getting the dose where you need it to be. And then beyond that, you're not getting much radiation. If you want to actually, if you pull up the, I think the second slide that I have, I can kind of give a sort of a graphical example of what I'm talking about. So
let's see. This one right here.
Let me see. Yes. So, this is a patient that had a very significant scleroderma as a connective tissue disorder involving her scalp. So we were very concerned about having to treat with external beam, going through what would not heal well. With the GammaTile there on the left, the red is the prescription dose and higher. You're blasting that surgical cavity, and then the blue's the low dose, hugs that region. On the right, this is done with CyberKnife, which is the most conformal, focal, precise type of external beam radiation that there is. And with its best attempts, you can see that we're overtreating the normal tissue. The red part is much larger. And then you have all these bands of green and blue. That's low dose spill that is going elsewhere. And as Dr. McCracken was saying, a lot of these patients with gliomas do recur. Well, in the case of this patient, if she does recur elsewhere just outside of the resection cavity, we have an opportunity to retreat. And there has been people that have gotten GammaTile up to 3 times. Whereas with the patient that had external beam, we might be limited as to how much we can go back in.
Yeah. And again, I mean, even for those who are not clinicians, you can see, I mean, GammaTile, again, what I like about GammaTile, and again, I don't want to speak for the company and the product, but like, I feel like this is a great example of what precision medicine is, which is you focus precisely on what you need to do and where you need to do it, by also avoiding, having impact on healthy tissue. And so again, CyberKnife is a great product and technology, but you still see a lot of scatter, A
lot of scatter, and no matter what, you'll have entry dose. I think the other thing that this slide shows really well is if you look at the upper left, that's the coronal view.
This one right here.
Those little white dots.
Those these white dots.
Those are the sources. So kind of what really helped GammaTile deliver this very conformal.
You're talking about these white dots right here, correct?
Yes. That the spacing in the gel really controls how spread out those seeds of radiation are, such that you get a nice conformal dose. Prior attempts at doing brachytherapy in the past for CNS malignancies, they didn't have a delivery vehicle like that. So the seeds would clump together. You'd get hot spots, you'd get cold spots, you'd get a lot of radiation necrosis. And that's kind of the one thing that's cool about this is we took something that was not very well refined that was used in the past, and a small little change, putting it in that matrix so that it's got some space off from the normal brain tissue, so it's not causing hotspots, and it's arranged in a regular pattern. You're getting these beautiful plans.
Got it. And that, it makes a lot of sense. And thank you for sharing that. And kind of a good segue, Dr. McCracken, maybe if you could walk us through a little bit about the procedure when it comes to implanting this. I would imagine that as a surgeon, you enjoy this because, being able to test your skills and be really precise in the procedure is important. But if you can walk us through a little bit on the procedure side, that'd be great.
Yeah. I mean, Honestly, there's not much to it. I mean, it is one of the easiest things that we are able to do. In other settings when we're handling radioactive materials, we typically wear lead gowns, thyroid shields. Sometimes we wear even lead gloves. But the dose fall off from the radiation tiles is so sharp and so small that we don't wear any protective gear within the operative suite. I always wear
I've never heard that actually. So you don't wear a shield, nothing?
I don't. The only thing I wear a ring badge on my finger. And as well, I also wear just a normal radiation badge, because what happens is when we pick these tiles up, we just use a small bayonet. I pick them up out of a lead tray and I place them within the resection cavity, just in a conformal pattern after we've resected the tumor, one by one. We place them so quickly, probably less than 5 minutes that it takes us to place them, that there's so little amount of radiation. It's much less than even like an X-ray that we would get like for a spine surgery case, or if we're doing a heart case, whatever it may be. And there's so much less scatter than just a standard X-ray. We don't even wear any lead coverings. And out of all the things, the ring badge that I wear, which is closest to the radiation material, it has never registered anything of significance. And so we really don't need to take much from a precaution standpoint. But from our standpoint, we do the surgery like normal. Once the tumor has been resected, then the radiation oncologists join us in the operating room. They prepare the tiles on a back table in a sterile fashion. We then pick them out one by one, place them, and then close up the brain like normal, and we're done. So it's a very simple procedure for us.
Fantastic. Now, that being said, though, I do have to ask the radiation oncologist who's here to kind of talk about like his take on the safety considerations, right? So, Dr. Peach.
So it's very, compared to other forms of brachytherapy, especially brachytherapy that's delivered in the operating room, it is extremely safe. So you have a couple of things going for you. One, you're placing this in a bowl that's surrounded by bone. It's a low energy X-ray compared to what we use in external beam machines where we need 6 feet of concrete. So the bone attenuates most of that dose. So once you have the calvaria placed back on top, there's hardly any radiation dose that comes out, and it's to the point where we have given it, not myself, but there has been practitioners that have used it in pregnant patients, which normally radiation's an absolute no-go anywhere in the body, external beam wise, for pregnant patients, because the photons, even if you're, say, radiating something up here, the photons do ping pong through you like a pinball machine and can get down to the pelvis. With the GammaTile, because it's enclosed in your skull and the base of skull is very thick, there's basically nothing that's being transmitted down into the body. So very safe. It's one of those things also that, I do prostate seeds. You have to sit there and give a very long list to your patients of don't be around little kids or possibly pregnant people for at least 4 months. If you have pets that are breeding, you don't want them to be sitting in your lap because they give off a decent amount of radiation over 8 months. These patients, realistically, by 36 days, they're not radioactive to the outside world. And when they are, and immediately post-op, it's such a small amount that is of no consequence, even to, small children.
That's fantastic. Now, talking a little bit more about that, Dr. McCracken, kind of, if you can touch a little bit on some of the, side effects and complications. Every medical technology is going to come with those, like some of the side effects and complications that come with GammaTile, and then how do you manage them?
So I think the biggest fear that we have is radiation necrosis, and Dr. Peach touched on this just a little bit, but it's basically a really severe inflammatory reaction of the brain once you've received too much radiation, right? So it's a combination of leaky blood vessels. It's a combination of inflammatory cytokines, dead tissue, swelling within the brain, and it's basically this. It can be very small or it can be very large, and we've seen both. Where basically you get a lot of edema or swelling throughout the brain, and a lot of this just big inflammatory contrast reaction within the resection cavity where it can spread, throughout that. I will say a lot of it is proportional to how many radiation tiles we've placed or how much radiation somebody has received in the past. The vast majority of patients that we have seen, we pick it up on MRI first rather than them being symptomatic and coming into us. So they may show a little bit of edema or swelling around the resection cavity. We typically tend to just watch that. And if it gets worse, we typically start with things like Decadron, which is just an oral steroid. In patients who are extremely symptomatic, maybe they've had a seizure, maybe they're now having new focal neurological deficits. Sometimes we move on to Avastin, also called bevacizumab, which is like a super steroid, which sort of tends to shore up the leaky blood vessels and sort of really reduce that inflammation. But thankfully, the vast majority of patients do not need that. But the vast majority that do, can be treated with either steroids or, bevacizumab.
Got it. Well, next thing I kind of want to make sure to cover, it's always important to talk about clinical evidence and how much there is. Usually, for me in my career, I've always been on with like new and cutting edge technology, which unfortunately does not come with very much clinical evidence. And so, Dr. Peach, maybe, as a radiation oncologist, can you talk about some of the clinical evidence that supports GammaTile? Because I'm sure in your due diligence process, you went pretty deep on it with GammaTile. So what's some of the clinical evidence that supports the use of it?
So I think probably the best evidence, and it was one of the things that really made me feel good about using GammaTile upfront for a glioblastoma for the first time, was Dr. Chen's series of recurrent high-grade gliomas. Basically, he had a single institution experience, but with 20 patients where these were recurrent grade 3s, recurrent glioblastomas, and GammaTile treatment resulted in median survivals that were, in the double-digit 20 months, which is something that you don't see with just treating with chemotherapy. You don't see with treating with external beam. Maybe really small recurrences treated with Gamma Knife, you'll see that kind of outcome. But these patients were living a lot longer than would be expected. And then also, they didn't really have any significant toxicity whatsoever. So, that Dr. Chen's experience, again, this is an early technology. We're working right now on the randomized trials to really, show that these single institution and personal experiences are what in the broad sense, but that's been good. Also, the initial work done by GammaTile to get FDA clearance, they had implanted a significant amount of patients that had brain metastases. And so, we're talking about dozens and dozens of patients. That, for me, was very reassuring as far as the safety profile of the product.
Got it. Fantastic. And Dr. McCracken, my next question is coming to you, but before we do that, I just want to remind our audience, if you have a question for Dr. McCracken or Dr. Peach, by the way, my dyslexia acted up. Sorry, Dr. McCracken, I switched, had a little typo there. Please go ahead and ask in the comment section. And by the way, quick shout out to Dr. Kankam, who said that he's enjoying the show. So Dr. McCankam, thanks for joining us. Dr. McCracken, when it comes to the effectiveness of GammaTile, how do you compare it to, let's say, other treatments when it comes to tumor control, and then also more, I don't want to say more importantly, but yeah, probably more importantly, patient survival?
So I'd say, some of the most comparable things, if you're doing focal treatment for, a brain metastasis, things like Gamma Knife, the stereotactic radiosurgery platform, CyberKnife, linear accelerator. If we're going to do it in a single focus treatment for smaller lesions, those patients tend to do really well. And some of the data supports it, not only from the trial, but some, of our single centers, where if you're treating smaller lesions, especially brain metastases, less than 2.5 centimeters, the local control is excellent, right? We start getting more concerned when the cavities are larger, greater than 2.5, 3, 4, 5 centimeters. And then we have to start fractionating the treatments, right? So not only we're just giving a single dose with external beam, we're giving 3, 5, 10, or even 30, right? So especially in GBM, where standard of care treatment is 30 fractions over 6 weeks. We're comparing that to a single procedure, right? So these patients, some of them are able to, obviate the need for coming back for long periods of time for radiation, but they're still getting a relatively bioequivalent dose, to the resection cavity. So it's honestly been pretty amazing. And there have been brachytherapy platforms in the past with different types of radioisotopes. There are different types of cesium stranded seeds, for one, that were in a different sort of carrier than what GammaTile uses. And ultimately, I think the GammaTile platform within the collagen, matrix that we place is very safe. It delivers a very conformal dose of radiation, and honestly, we've been tremendously pleased with it.
Well, that's fantastic. One thing I wanted to cover. So patient selection is like the most important thing, of course, between a neurosurgical oncologist and radiation oncologist. Being a team and really selecting the right patients for this. Can you walk us through? I mean, whoever wants to go first, please go first. But what kind of factors do you consider when it comes to patient selection, and who, we can talk about what makes a good candidate for GammaTile, but also I would like if you could maybe share who's not a good candidate for GammaTile.
So, I mean, I always look at number one, is this a tumor that I can get to, right? Is it surgically accessible? And can I either get a gross total resection where basically nothing shows up on the MRI afterwards, or a near total resection? Because that's very important, because if you leave too much tumor behind, then the reach of the GammaTile is not going to affect that tumor appropriately, right? And then you're going to have to also get another dose of external beam radiation. So in my mind, if it's not something which can be removed almost completely, I don't even consider it, right? Or there just has to be a very small amount of residual left. So that's the first consideration. Number two, are they going to need radiation, right? So these patients have to obviously need radiation afterwards. If they're not going to need radiation, we're not even going to consider it too. We talked about the need for patients who may need to go to rehab, and we're worried about a rapid early progression of tumor. And so we say, are they going to need to go to rehab? Do they need radiation? Could this patient benefit so that they don't have this progression of tumor while they're waiting? That, or do they have transportation issues, right? Is this patient, we're going to back off to rural Georgia, and are they going to come back and get some type of therapy or not? If the concern is maybe not, then I absolutely consider those patients too.
And Dr. Peach, how about you?
Yeah, so I agree with a lot of what Dr. McCracken was saying. It's we're looking for people that are good operative candidates, and it also depends on the situation. If it's a primary CNS malignancy, a lot of times how far do they have to travel? What are some socioeconomic things that might interfere with getting external beam radiation? Those are factors. When it comes to the metastatic patients or the lower grade gliomas, the meningiomas that just keep recurring, I'm spoiled in that I have Gamma Knife, I have CyberKnife, I have, the top of the line linear accelerators. And so we have a very robust Gamma Knife radiosurgery tumor board with medical oncologists, neurosurgeons, radiation oncologists. And we'll sit there and we'll look at it. And if it's a patient that's had multiple treatments, we'll kind of look at it and say, all right, can we fit this other form of radiation in? Would it leave enough room for GammaTile if we had to do it, 3 years from now? Or, we're not going to have that. We should do GammaTile now. So those are some of the kind of bigger picture considerations, because in the end, what we're trying to do is not burn bridges with other therapies and trying to maintain the quality of life.
Got it. So then on the flip side of that, what would be some of the main contraindications to it?
I think one is, if someone has a very, very poor performance status, that's one of those situations where we might question, do we want to even, does the patient want to even do a surgery given the potential morbidity? So that's one thing you kind of are looking at. Healthier patients, they don't have to be in tip-top shape, but if they are sort of unfortunately at the end of the road, that's something that we're not looking at. Again, the thing that we're being more cognizant of now is tumors that are right around the optic structures. Not a situation that we see all too often. And then and one thing that can get in the way, unfortunately, it does still happen, is we do have some patients that have MR incompatible pacemakers and other equipment in their body. So if you can try to plan off of a CT scan, but it's just not.
That's just tough. It's just a
there's
different
lot of
imaging modality.
Yeah. So
Yeah,
that doesn't, unless we're sort of in a more ideal situation, that kind of will preclude a lot of people, which again, not a situation that happens all too often.
Got it. And then, like, just in general, one of the things I like about new technology specifically like this is that what do you see if you were to scope out 5-10 years from now, 15 years, in terms of the future when it comes to GammaTile treatment and therapy? Where do you see that going?
So, I mean, I think the one thing, if you want to bring up my last slide.
Yeah, absolutely.
The thing that I'm the most excited about, and Dr. McCracken has touched on this too, is the utilization of GammaTile for glioblastoma. When we were initially using it, it seemed
this one right here.
Second to last. Just one up.
Right here.
When we initially used it, we kind of thought, oh, this is great for patients that, live far away. We're going to have a hard time getting external beam. Then, the eureka was, wow, we can really use this for patients that have these more benign tumors that just keep coming back. But then, we've had phenomenal success treating glioblastoma up front. And where I see things, and that's where the GammaTile is going now with randomized trials, looking for the upfront use of glioblastoma. This slide basically shows that the progression has been slow for glioblastoma. Maximal safe resection gave historically 3 to 6 months. Then we found out add external beam, that helps a little bit. If we go up to 60 gray, we're looking at 12 months. Then you add temozolomide, you're getting a little bit more in medium survival. You had tumor treatment fields, which is an alternating electric field that you unfortunately have to wear for 18 hours a day. That really pushed it a little bit further in the ideal patients. But with regular dose escalation studies with external beam, going beyond 60 gray didn't get any benefit. But with GammaTile, for many, many, many reasons, I think that the experience that Dr. McCracken and I have had with patients who are more than a year out with no evidence of disease recurrence, we're going to see that in the randomized trials. And that's because you're getting immediate radiation just after surgery. You're getting radiation over, approximately 28 days, where it's constantly chipping away at any residual seeds. And at the same time, you're getting, more biological dose than you would with standard radiation therapy. So that's kind of the thing that I see is in the future, GammaTile being kind of the next big milestone for glioblastoma treatment.
Got it. And, so, Dr. McCracken, let me come back to you. Like, for physicians who are interested in getting, learning more, essentially getting trained, because obviously you can't just, you have to get trained for this. Like, what's the best way for them to learn more about it and also get trained?
Honestly, starting at the website is a great place to go. They can help you find, centers which do it. There are tons of wonderful reps probably, close by that can also help. And then, people like, Dr. Peach and myself, I mean, we talk to physicians all the time who are interested, who want to learn, hey, is this patient a good candidate or not? How many tiles should I order? Can this physically be done? So, use this as resources, because we do this all the time and we're happy to share our experience with people.
Absolutely. And then for those who are listening on our podcast, you can go to gtmedtech.com and you'll be able to find some different events and different ways to get trained there as well. Fantastic. So maybe let's jump into something a little bit more interesting for both of you. If you could share maybe a case study where GammaTile did make a really big difference in a treatment outcome. Feel free to take it in any direction. Again, I have both of your slides ready if you need me to reference anything.
I'm happy to show one. Do you have mine, Omar?
Yeah, absolutely. Which slide do you want me to go to?
How about that big malignant meningioma?
Oh yeah, that's a really good slide. Yeah. Let's see.
So this was
so let me go to it real quick. So that, for those who are watching, that's the actual device. That's the GammaTile, and you can see how small it is. Yeah. But let me see. Was it this one right here?
No, keep going.
Keep going. Oh, I know. I remember which one it is. No, not that. Here we go.
Right,
yeah.
So this was actually a great example of a couple different, things that we've talked about where, this was a 65-year-old gentleman who was from the North Georgia mountains that had actually been treated by a colleague of mine about 6 months earlier, had a large tumor similar to this, but not quite as big. He had resected it. It came back as a grade 2 meningioma. In all fairness, the data out on grade 2 meningiomas is not great. And so I don't blame him for not giving radiation to this guy up front. But basically within 6 months, this tumor had completely recurred and almost doubled in size from his initial tumor. And so this guy was very adamant.
I was going to say, this is a pretty rare looking meningioma too, because usually I'm used to them being like really round and demarcated. Yeah. This is like deformed. This is a rare case. Would you agree?
It is. And ultimately, this was scary because if you can actually look, there's actually tumor coming out of the burr hole in the bone underneath the scalp. And so you can see there.
Here, let me zoom in on that.
Yeah, a little deformity on the scalp.
Right there.
No. Go to that top left corner. The top left picture. There you go. You can actually see it right there. There's actually the deformity in the scalp where there's actually tumor coming out from under the bone into the scalp. And so
when you examine the patient, were you able to actually see it upon physical examination as well?
Oh, yeah. Yeah.
Oh, wow.
Yep. It was like a small horn in the top of his scalp. And this guy was adamant that he did not want
right here, correct?
Come back for radiation. That's right. He did not want to come back for radiation. He really didn't want to come back to Atlanta to get any more treatment. So we kind of knew we had one chance to help him. And so we knew this was going to be aggressive. We knew he didn't want to come back for treatment. So we said, let's go back in again. Let's put tiles in. And so when we went back in, we were able to get a very nice gross total resection on this gentleman. This came back as a grade 3 meningioma, so a malignant meningioma. We laid down 18.5 tiles. So this is a massive tile case for us. In comparison, the average number of tiles are placed are between 4 and 6, probably. So this was a massive case. And so, but thankfully, this gentleman had no evidence of local recurrence for 2 years after this. And so this just goes to show you that not only did he not have to get external beam, he went on from a local, control standpoint to do extremely well. And so I love to show this case because it just shows, I think sort of the power of it. And, kind of really highlights some of the things that we've talked about for, how we use these and how we select patients for this treatment.
Yeah. And again, just as an outsider observing this, what's unique is that, I would say this is kind of like a zebra case, right? So not all cases are going to be like this, but I think that having that ability to use very precise deliverance of radiation therapy, whether it's your usual case when it comes to meningioma or glioblastoma, or this extremely rare case, it must feel good as a physician to have more control versus, again, and I don't want to like knock any other products, but like the old way was that you have sort of the scatter approach, right? But this way you have a much more tailored approach and you have more control, as a neurosurgeon and as a radiation oncologist. Am I right, gentlemen?
It is a tool we didn't have 5 years ago, right? And 5 years ago, we probably would have done our best, given him external beam, and he probably would have had significant frontal lobe dysfunction from all the radiation we would have had to give him. And so now it is another wonderful tool that we are finding ways to incorporate into all these different disease processes. And so you're right. I mean, it's one of these things that we are bringing it up more and more in all of our tumor boards, and we're seeing it pop up more and more in all these different, clinical trials and, single institution series. And so I'm thrilled to see it. And I hope really, more people adopt it, because I think it is a wonderful, tool for us.
No, absolutely. And Dr. Peach, anything to add any cases you want to reference?
Yeah, so I think the case that really got me excited the most about GammaTile was that first glioblastoma case. So if you could go into my slide deck, basically this was a younger patient who had both psychiatric and drug abuse issues that basically was living on the streets.
Pull that up real quick.
Parents couldn't control her. And so when we talked about treating her,
this case,
no, keep going. Next one.
This one right here.
Oh, no, one back.
One back.
Yeah, I believe so. Oh yeah. So this thing went from being just a little ditzel that we were like, man, maybe it's a low-grade glioma, to looking like this in 2 months. So this was, even within glioblastoma, is very aggressive.
That's extremely aggressive. How old was the patient?
She was in her early 40s, and
Oh, man.
And otherwise was doing pretty functionally well. But she had all these social issues, and so thinking about doing 6 months of radiation therapy. 6 weeks of external beam radiation therapy, we didn't think it was going to be possible. So we talked to her, and this was, very early on. This was before, there was anyone had talked about doing glioblastoma at other centers. And so we figured we can at least treat the tumor bed with this, and she'll at least get that, and now at least keep things under control for a while. So we went ahead and did that. And what ended up happening was that she, after the surgery, really cleaned up her act, was stable. So we saw the parents about 4 weeks out, and I was like, well, do you think she could get external beam too? Because typically with glioblastoma, you treat the dose right around the surgical cavity to a high dose of 60 gray. And then because it is very creepy crawly, we do a moderate dose outside of that. And so she was missing that moderate dose aspect. So we went ahead and if you go to the next slide. Oh, so that was the dose delivery from the GammaTile. So then we spent, and this attests to, if you go to the next slide, this attests to, when you're asking about how can people learn about this, how they can get support with this, the people at GammaTile have been amazing to work with. And this is one of the best demonstrations of this, in that we worked with the inventor, Dr. Brockman, as well as the main physicist, for weeks trying to figure out how do we convert GammaTile to like external beam dose. And then I had very talented dosimetrists who figured out a way to basically create a donut hole where the GammaTile dose was and have it match up to what was delivered already. And that's the donut hole is what the external beam is on the left. And then the combination of the two, this is ideally what you want to do for an external beam plan. High dose in red, moderate dose in yellow is on the right. And miraculously, the one thing that I noticed was that, at the planning scan for the external beam, there was no recurrence of disease whatsoever. There wasn't that rim of disease that was growing, which we often see. And then if you go to the next picture.
This one right here.
She's now almost 2 years out, and that's what her imaging looks like. This is the kind of imaging you don't see typically with glioblastoma. Really no evidence of residual disease. And also in this case, and with her, because we're combining the external beam, we're doing this dose matching. I was really worried about radiation necrosis, and we don't see any of it. So this case really was just showed how well it works. Had an amazing impact on this patient because she really cleaned up herself. I mean, this was like an awakening moment for her to change how her life was. And normally, this might come too late, but she's now had 2 very great years after her surgery.
That's amazing. That's amazing. And, just in wrapping up, one, I want to have both of you share some final thoughts, but, one of the things I wanted to cover, but then just coincidentally, so sometimes, again, I'm going to encourage our audience, if you have questions, drop it in the comments section. That being said, some people have questions where they do not want to be identified, so they usually DM me. So I have a question, a physician question, and it was kind of a long one, so I kind of summarize it here. But essentially, what this physician was asking, she wanted to know, like, what's the best way for me to get my hospital to adopt this, like, outside of her clinical support? And I think the biggest thing is that as clinicians, let me put that as a scroll real quick. I think as clinicians, providing your clinical support and validation to the technology, that's what every clinician knows how to do. I think where they struggle is just thinking like, okay, like, how do I go forward, like, to the value analysis committee, and how do I get more support? For me, I think like recruiting other clinicians to support you is always helpful. But I'm wondering for both of you, I mean, what's your advice to physicians in terms of how do you go about like really pushing the hospital to adopt this kind of technology?
So I think that, and I'd love to hear what Dr. McCracken thinks about this. From my perspective, I think the buy-in from radiation oncologists is one of the more rate-limiting steps. For neurosurgeons, if they talk to a colleague who has done it, they realize that this really is not adding much to doing a craniotomy and a resection. For radiation oncologists, a lot of radiation oncologists don't do procedural radiation. And when they think of procedural radiation, they think of being in the OR for an hour or two or more. Because that's kind of, if you're doing seed implantations for prostate therapy, you're in the OR for a long time. And that doesn't work with a lot of smaller centers where there's only one radiation oncologist.
Right.
With this, I think it's really letting the radiation oncologist know that your role in here is mostly on the front end in trying to figure out how many tiles there are, the back end to show how much dose you got, and the actual delivery of the tiles is 10 minutes. So it's really not a.
So radiation oncology, it has to be in the room, but rather than a few hours, they're in there for like 10 minutes because it is small. It's a rather quick and easier procedure. Is that correct?
Yes, the neurosurgeons are they're the heavy lifters in most of this. So yeah, it's very our role is very, very brief as in the OR, that's the big concern with radiation oncologists. So I think the adoption, I think that one of the big hurdles is radiation oncology, and if they really get to talk to someone who's a practitioner and know kind of realistically what does this mean for them as far as their schedule, they wouldn't be so averse to it.
Got it. Dr. McCracken, how about you? What are your thoughts?
Yeah, I mean, I will say that initially our hospital is very concerned about the reimbursement from an insurance standpoint. Ultimately, with an implantable surgery, the DRG, which ultimately results in the reimbursement to the hospital, actually gets kicked up to a higher reimbursement type of DRG for the hospital. So, they were really concerned about, basically the cost of the product, minus the expenses of the surgery, what they would ultimately return. And, we've done now almost 60 cases here at Piedmont. And I don't think we have yet to lose money on a single case from either whether it's commercial or Medicare reimbursement. So that was a very strong driver for us about implementing something like this. And then I agree with Dr. Peach. I mean, you have to get buy-in from your physicist team, your radiation oncology team, your neurosurgery team. But ultimately, I think once you start seeing the benefits to patients, and a lot of these patients that you may have had no options at all, and now you're actually able to provide them with something, then I think it's a win-win for everybody ultimately.
Got it. But just to kind of play out, to reference back what Dr. Peach said, it sounds like the rate limiting step here is to make sure that the radiation oncology understands and champions the product, because if you can't do that, then like doesn't matter how many people you get behind it, radiation oncology can block it essentially.
Yeah, and it's one of those things. Oh, sorry. Go ahead, Dr. McCracken.
No, I was just going to say, I mean, and he knows better than I do, but I mean, ultimately, they're the ones with the license, to hold the material, and so I mean, of course, you have to have radiation oncology buy-in.
Yeah, and I think you gotta look at the big picture. The reimbursement is getting less and less for radiation oncology as time goes on, as with most fields of specialties in medicine. But what the hospital will get as far as reimbursement from the radiation side versus how much effort that we have to put in from the radiation oncology standpoint side, it's very little effort. So from a reimbursement per time standpoint, it's very good. The other thing is that system-wise, when you're talking to the hospital, and this was a discussion that we had with our system, was these patients are living longer, and they're, when it comes down to the whole, even if you weren't able to charge to the higher level for the craniotomy and resection, these patients are ending up getting more modalities of treatment later on when they pop up with disease elsewhere, because we're now in the kind of oligometastatic phase of cancer therapy, where if you have just a few metastatic lesions, it's not game over. We can spot treat those. People are living very long with that. So the long-term benefit financially to systems, it's a major gain. You just have to, present that to the decision makers.
Got it. Understood. Well, and just, again, we're at time, so we appreciate you spending some time with us, but if both of you can kind of wrap up, give your kind of final thoughts, to physicians that you want to share to people listening, whether it's here on the live stream, but of course, like, this is going to be on a podcast and everything. Any final thoughts about GammaTile, the approach to this procedure and the adoption of it?
I mean, I would just say that, we initially started this with treating, the worst of the worst patients, right? I mean, people who had no options, and then, quickly, really, developed our program into treating patients with upfront brain metastases and GBM because we were seeing such good results. And so it does take a little bit of belief, because there's not a, dearth of data out there. We are working on that with multiple clinical trials going on. And so I think that we're going to see really good data within the next, couple of years after all these centers have put forth all their data. So it does take a little bit of faith to adopt a new technology like this. But I think, anecdotally from our center, from Sean's center, from, MSK, from MD Anderson, all these people who are using it, we're really seeing, tremendous results with respect to local control and overall survival with some of these really, aggressive tumors. And so I think it is absolutely worth looking into if you're a center that treats brain tumors. And it's a wonderful extra tool that, we didn't have years ago that we do now, and it's worth incorporating.
Got it. Fantastic. And then Dr. Peach, how about you? Kind of take us home.
Yeah, I mean, I totally agree with that. It's a tool that, was very niche at first, but as time has gone on, we're just finding more and more uses for it. And that's having significant impact on people's lives. For the non-radiation oncology crowd, I guess I would say my excitement behind this being a brachytherapy platform is, in oncology, they always talked with chemotherapy about the hypothetical magic bullet, being able to put a toxin right in the tumor to kill the tumor. With brachytherapy and GammaTile, that's the radiation equivalent of it, of being able to put the radiation just where you need it and not having all the toxicity that comes with it going elsewhere. And so, again, because we don't have the limitations of entry dose, we don't have the limitations of slower dose fall off, as these studies match to the personal experiences that practitioners have had, I think it's going to make a very big impact for CNS oncology.
Fantastic. That being said, we're at the hour again. I really appreciate you guys spending some time with us. I just want to remind the listeners, for those who are listening live or on recording, if you're interested and you want to get your CME credit, you do get an AMA PRA Category 1 CME credit from this. You'll be getting an email, or you can just follow up with your local GT medical representative, and they'll be able to provide that link. And for those who are interested, go to learn more and also get trained on GammaTile. Just head to gtmedtech.com. A lot of really great resources, very interesting things that you can check out there. So that being said, my name is Omar Khateeb. This is another episode of the State of MedTech. Dr. McCracken, Dr. Peach, thank you so much for joining us, and we'll see you all next time.
You're welcome. Thank you.
All right, everyone.
Thank you for enjoying another epic episode of the State of MedTech. If you're feeling inspired and love this episode, do us a favor, hit that subscribe button and turn notifications on so you never miss an episode. And be sure to give us 5 stars and write a short review, because that helps more people discover this amazing community of ours. If you're a company who has a executive that you'd like to be on the show, or perhaps you want to sponsor one of the episodes, shoot us an email at hello@khateebandco.com. Take care, and we'll see you next time.